Dr. Hess was born and raised in Georgia, completed his college degree at the University of Florida in 3 years, graduating as valedictorian. He attended Duke University School of Medicine, receiving his MD at the age of 23. Pretty amazing, I think. Dr. Hess completed his internship and residency in internal medicine at Duke University and his fellowship in cardiovascular medicine at the University of California in San Francisco. By the age of 28, Dr. Hess was board certified in both internal medicine and cardiology. At the time, the youngest person to ever obtain both such certifications. As an assistant professor of medicine at the University of California, Dr. Hess led the cardiac team that performed the first catheter ablation procedure of a cardiac arrhythmia, a technique that is now used worldwide to treat a variety of heart rhythm disorders. After leaving academic medicine, Dr. Hess became a partner in a large private practice cardiology group in Jacksonville, Florida, where he spearheaded the development of outpatient cardiology procedures and new cardiac imaging techniques. Dr. Hess is currently retired from the practice of medicine. I think we're pretty lucky to have Dr. Hess here. And the other good thing about him is he's a great speaker and he's fun to listen to, so I'm going to turn it over right now.
Thank you, David. How many were here about 2.5 years ago when I talked about Obamacare? Remember how depressing it was? Today's is worse. Barry asked me, I guess about a month or two ago, if I would speak again on Obamacare, and I said I'd be delighted to. And it gave me an opportunity to go back and look at what has happened since 2014 when I last spoke. And as you know, when I spoke last time, I have to turn on the projector. Let's give that a second to warm up. When I was here in 2014, I nicknamed Obamacare Deadly Medicine. The sequel today, we could probably call it Deadlier Medicine, but it's hard to get worse than it already was. My projector's coming on. The source of my information from today comes from several things. First are scientific studies published in the literature. Second is from healthcare management organizations and journals. And thirdly, talking to those that are still in practice that I know from around the country and in Arizona. My wife Pam was a healthcare consultant for years, and she has contacts throughout the industry, and so we always talk to them about what's going on. All right, deadly medicine. Now, in 2014, I went through how Obamacare was legislated, designed, and implemented, and we together made several predictions about what would happen. We said absolutely costs will increase, access to health care would be limited, and there would be a shortage of MDs. 30 months later, we can say health care costs did increase. For instance, Pam and mine's health insurance doubled in a period of 3 years. So no one, if you talk to employers, as a matter of fact, I just talked to Christian, who's on an Obamacare plan. He's young, healthy, has no problems. He's only insured himself. It cost him almost $9,000 a year between his deductible and his premiums before he gets a single penny reimbursed by healthcare. And for most families, that's a huge burden. Access is limited. Many of the Obamacare programs or plans that are sold in northern Arizona, your specialist is in Phoenix. They're not in our area. And lastly, there is an MD shortage. Anybody ever tried to get a new physician lately? I called up to get my routine colonoscopy, 8-month wait. It's a good thing nothing's actually wrong down there. Now, I hate to say this as a very conservative Republican, but the trajectory of what's going to happen in healthcare is set, and nothing is going to alter that. You can talk about repealing Obamacare, but that will accomplish nothing. You can talk about private insurance, selling policies across state lines, only having catastrophic coverage, getting rid of the coverage for all these other ancillary things that Obamacare did, that will not solve the problem, because what has occurred in the last 10 years has set healthcare on a trajectory that no one knew where it would end up with, but the smart people in the industry will tell you what I'm going to tell you today is going to happen. Now, before I tell you what's about to happen, which is not good, I want to tell you how it used to be in the good old days. There were 3 components to healthcare when I grew up, when I was in training, and during most of my practice. First was the hospital, which was easy. That was the location of the care. At that time, in the 60s, 70s, 80s, and 90s, most of the time, the customer for the hospital was insurance companies. That's who bought their product. Then there was the insurer, who was actually the payer of the care, because most of us had our care paid for by some type of insurance. And the insurer's customer were employers or the individual market. And then last, but obviously not least, were the doctors. The doctors are the ones who actually provide the care. They were the most important component of healthcare in America. And we're heading into an era where they will become the least important part of healthcare. Now, doctors were the patient's advocate. And hospitals and also insurance groups always catered to the doctor. Doctors controlled where patients went to the hospital when there's more than one hospital. In our community, you got to go to Yellow Regional. But in most communities where there's more than one hospital, in the good old days, doctors controlled where the patient went. So hospitals competed for doctors' patients. And the doctors had to be satisfied with the equipment, the nursing staff, customer service at the hospital, and hospitals competed with each other to please doctor groups. When I was in practice in Jacksonville, Florida, I had a huge cardiovascular group, a huge referral base, and hospitals were always asking us to change to their hospital and all the things they would do for us and their patients. Those days are long gone. Doctors no longer control where patients go for their care. Now, the doctors are no longer God. We've all made the jokes. There comes Dr. Hess. He thinks he's a god. And most of the time I did. And most of the time it was merely true. But that is no longer the case in healthcare. Because right now, 60% of all physicians practicing in America are employed by someone else. That is usually a huge multi-specialty group, or in most cases, like locally, but a hospital. Now, in the 1960s and 70s, if you look at demographics, and this came up the other night when I was talking to someone, 93% of students who were in medical school were white males. 7% were women and minorities. And that was because what drove people into medicine was it was a dynamic field. You could be independent. And physicians in those days had an unwritten pact with society. And that was, I would care for you, I would be available, I would be your advocate, and I would be available 24/7. In return, I entered a profession that was highly revered and respected. I could be part of any community I wanted to move to. I had a nice lifestyle, and when I retired, I had a comfortable retirement. What I gave up for that compact was medicine became my mistress, and your family life suffers. Of the 104 people in my medical school class from 1974, not a single person is married to their original spouse. That was the cost of physicians during that time. That's no longer the case. Physicians now say that their number one goal is lifestyle. Their number 2 goal is family. Their number 3 goal is time off. And somewhere around 8 or 9 are you, the patients. Now, since we have become employed by other bean counters and administrators, none of whom have medical training, have morphed what we do in the waiting rooms and in the exam rooms and in the hospital from an art to a science. and there are checklists. If you have this problem, you have to run these tests and give these medicines. When I was in practice, each patient was different. Not every known treatment was the best for every known patient. And then what I call, you have become an algorithm. You ever seen those flow charts that scientists draw? Chest pain, male or female? Yes. With exercise? Yes. And you look at these flow charts, and that's what physicians do nowadays. They follow the flow chart. You just happen to be the person that entered the flow chart. Now, the computer is God, no longer the physician. In 2009, our esteemed president, when he was trying to revive the economy, said that they mandated that all medical records be electronic and computerized. It had to be implemented in 2014. The initial estimates by the government was underestimated at $100 billion to computerize medical records across the country. $27 billion was targeted to physician practice groups. Kaiser Permanente, which is one of the largest healthcare organizations in our country, says it costs $500 to computerize medical records for every patient. They estimate that when we're done, it's going to cost our country $1.5 trillion to computerize medical records, which gave us the promise of better care. Those who designed Obamacare think they're the smartest guys in the room. And they think if we computerize things and we know when you have and have not received a therapy, and we can penalize doctors for not prescribing it, you're going to get better care. We now have about 10 years of scientific research on looking at computerized medical records, and there's not any hard data that it has improved your care. Tablet medicine. Anybody been to the doctor and they sat there with their tablet? Did he even or she look at you? Okay, their finger and their eyes are on that tablet. It's like they're hypnotized. I accused my cardiologist, who's a good friend of mine, that he was watching porn the whole time he was trying to do my history. This has become a priority with healthcare systems now, as this stupid electronic checklist. They link payments and penalties to hospitals and physician groups based on how effectively they fill out the checklist and how effectively their patients are rendered care. So for instance, they'd rather know that 100% of you have had a tetanus shot than to sit down and actually take a history of where are you hurting. That is how they are grading healthcare and how they are rewarding. And they collect unbelievable amounts of personal information. Now the government will tell you it is not required. But I can tell you 99% of people that go into the doctor are so afraid of aggravating the doctor and being fired as a patient, they answer these questions. And they're very personal. It's about illegal drug use. It's about whether you have a gun in the home. It's about whether you've had mental illness. You may have come in with a scratch, and they want to know all of this information that is unrelated to your care. And I can tell you it has not happened, but there's going to be major breaches in these electronic medical record systems. And if you are a person in public life, whether you're an elected official, police chief, physician, wealthy person in the community, this will come back and will be published in the newspapers because it's going to become available. Now, in the old days, they came up with HIPAA. God, what a name, HIPAA. Health, Insurance, Portability, and Protection Act, okay? Let me tell you that when I was in practice, if I did your history and physical and was typed up by our transcriptionist, it was on paper, and it was in our file cabinet, it was more protected than your records are now. Because you literally have to break into my office and steal that and then Xerox it if you can figure out how to turn on my Xerox machine to steal it. Now, it's in the cloud. The servers that function for Yavapai Regional Medical Center are in Cleveland. Okay? I found that out when I went to get medical records. The new medicine. Oh, I love the new medicine. The new medicine is based on several things. First, it's test versus history. A well-trained physician can sit down with someone with chest pain as a symptom and 95 to 98% of the time tell you if you have heart disease before they even examine you. After they examine you, that goes to about 98%, and then they may or may not order the appropriate test. Now, when you go in to see a physician, and most likely it's a nurse practitioner or physician's assistant, and you say chest pain, there's no other description to the chest pain. They then go, you need a stress test. Now, Jerry Robinson is in the crowd. He's a retired cardiologist also. Chest pain from heart disease has particular characteristics. It's usually in the middle of the chest. It's usually dull in nature. It usually comes on when you exercise. It usually goes away within 3 minutes when you rest. Can't go to your neck or your arm. It's usually associated with people in my age group with certain risk factors. But when a 32-year-old woman comes into a medical office with chest pain, the last thing they need is a EKG and a stress test. They need a complete history and physical examination, and that's just not being done because algorithms reign. If you have chest pain, you have to have these tests, and depending on the result, you have other tests. What this results in is unnecessary testing, and 5% of all tests are read improperly or are abnormal when they really are not abnormal. And all this does is drive up costs and quality goes down. Now, the other thing that the people who are smarter than the rest of us said that electronic medical records will improve physician productivity. There was just a recent article in a journal about medical records, electronic medical records. It's this whole industry now. It's unbelievable. And they found that on the average in most electronic medical records, it takes the doctor 33 clicks to order a flu shot. Now, when I was in practice, my medical assistant's name was Barbara. She was smarter than most of my partners and better than any nurse I ever had. So if I had gone and say Barry had come into my office and we were talking, and we took care of our patients in a general way, and it was coming flu season, and he said he hadn't had a flu shot, I would walk out into the nurse's area and I'd say, Barbara, Barry needs a flu shot. 6 words, 2 seconds, it's done. Now they have to have 33 clicks. They estimate that physicians waste 30 minutes a day just signing in and off of their computer because for your protection, they are programmed to sign you off if there hasn't been any activity in a certain amount of time. A recent study came out that family physicians and internal medicine specialists spend an average of 38 hours a month after hours between the time from 7 p.m. to 7 a.m. the next morning just doing data entry. So every month they work the equivalent of 1 week just putting stuff in the computer. Okay, that takes them away from thinking about you as a patient and spending time with you as a patient. Which brings me to my next pet peeve, which is how much time does the doctor spend with you? When I was a medical student at Duke University, Dr. Stead was the head of the Department of Medicine, and he was a respected and really feared individual. You did not want to cross Dr. Stead, because if you messed up really bad, you wouldn't be there the next day. Okay? You kind of like disappeared. He didn't kill you, but he exiled you. And it was unlikely you ever practiced medicine after that. Dr. Stead had his first axiom was, if you talk to the patient long enough, they will tell you what's wrong with them. And so as you go through your medical training, you start out as a student knowing nothing. And if you're sent in to see a new patient who's just been admitted to the hospital, you're going to spend about 2 hours learning all about the patient and getting their history and doing a physical examination. And as you advance in your medical education, by the time you're an intern at Duke University, you'll spend about an hour to an hour and 15 minutes when a new patient comes into your ward, we used to call them, or your hospital setting for some kind of treatment. The residents, as you know, is the next level above an intern. They're at the point where they think they know everything, but they don't know quite everything. But they're really good physicians. By the time I was a resident, I could take a complicated new patient, spend an hour with them, and I was in really good position to know what was wrong with them. And when I went into private practice, for a new patient evaluation in our cardiac group, you were allotted 1 hour, and we generally spent 45 minutes with the patient on the average, some more, some less. Now, anybody want to raise a guess as to how long the average resident spends with a new hospital patient? Remember, when I was a resident, I spent 1 hour and 15 minutes. I got 10 minutes. Do I have any other bids? 15. Oh, that's a good one.
I say 3.
Oh, she's been in the hospital recently.
I timed it.
Yes. It's 8 minutes. I can tell you as a resident, in 8 minutes, you can barely walk in the room, sit down, scratch yourself on the nose, and introduce yourself. You cannot get any meaningful information from the patient in 8 minutes, and that's a resident. It totally floored me. Now let's talk about when you go to the emergency room and the computer. Remember, the computer is God. The physician is now ancillary. The average, this was a study in emergency medicine, the average doctor in the emergency room sees about 2.5 patients an hour. 56% of their time is spent with the electronic medical record. And they spend an average of 6.7 minutes with the patient. Now, sometimes that's okay. You go in and it's a child and they've cut their foot. Doesn't take much of a history to know what you've got to do. But the vast majority of patients coming in the emergency room have diabetes, heart disease, lung disease, etc. And it takes longer to do that. Not spending time with the patient and finding out what's wrong with you is hurting medicine, driving up cost, and driving down quality. Deadly medicine. Has anybody heard the term ICD-10? I talked a little bit about it last time. ICD stands for International Classification of Diseases, and it's how hospitals and doctors code to get paid, okay? That's why they exist. Now, in the Obamacare administration in 2009 going forward, they decided to update these codes. The last iteration, it's kind of like Microsoft Windows, you know, it goes 7, 8, and then it jumps to 10 if they got smart. So ICD-9 was what we last had, and it had 13,000 possible diagnoses. When they went to ICD-10, it jumped to 68,000 different diagnoses. They wanted to code for every possibility. They didn't just want to know that your left hip was replaced, they wanted to know, was it from arthritis? Was it from a traffic accident? Was it from some other kind of accident at home? Was it from an old football injury? Was it genetic? You can't believe how much detail it went into. That's because they want to collect as much information as they can so they can make more regulations and algorithms on how to care for you. The government knows everything about you. You need to think about it. Now, I just want to give you an example. So this is a code that now exists, V97.33XD. Don't ask me what any of that means, okay? This is a diagnosis for the following condition. The patient has been sucked into a jet engine. It is the second occurrence. Okay? I didn't know you could survive being sucked into a jet engine. Much less be so stupid it happened a second time.
I was a Democrat.
Oh. Well, a Democrat obviously wrote that code. That is a real code. Okay? Now look at this one. This could be a nuclear launch code. Look at the length of this thing. This is my all-time favorite. Burned from water skiing while the water skis were on fire. Subsequent encounter. First off, I assume if you're water skiing, you're in the water. How can they even catch fire? Secondly, if you're stupid enough to do it the first time, why would you do it again? Now, I don't know if anybody's ever been coded by it, but that's the junk that is in electronic medical records today. Now, let's get a little serious about the medical field, healthcare profession, etc. Did anybody see this study? It was published last week. It was on some of the news channels. Let me tell you a little interesting thing about this. This was a study done in the British Medical Journal, highly respected medical journal. The study was done by a Johns Hopkins surgeon. So you're thinking, okay, Johns Hopkins, a very fine institution in America, a surgeon who works there has got to be highly respected. Why is this published in the British Medical Journal and not the American Medical Journal? I don't know, just think about it.
Obama wouldn't let him publish it.
Probably so. It showed, based on studies they could determine between 2009 and 2013, that medical errors killed 251,000 people a year. And I believe that. I think it's actually low. That makes it the third leading cause of death in America behind heart disease and cancer. The healthcare system, doctors, nurses, pharmacists, everybody's working in the hospital system and in the outpatient system. Medical errors kill more people than lung disease, suicide, motor vehicle accidents, and gunshots added together. Now, Pam, when I was telling her this information, she says, well, the Democrats say that if there's 34,000 people killed by guns, we should ban guns. So I guess they're going to ban doctors now that they killed 251,000 people a year. And they might try to do that. Now, they code for everything. If you remember, I said they code if you fall into a jet engine or your skis get on fire. But there is no code for death by medical error. You cannot determine it from any code that's in the electronic medical record. You have to read the record to determine it. Think about why that is. They don't want us to know. They don't want you to be afraid to go to the hospital. They don't want you to demand better care. They don't want you to demand excellence. So they hide these facts. In the state of Arizona, and I need to talk to Noel and Karen about this, there is no law that requires hospitals to report their infection rate. Many states across the country have made that a law. Hospitals have to report their infection rate for common procedures. We're one of the states that don't. We as consumers need to start demanding these things because healthcare has become rather dangerous. Now, the next thing that's happened over the last 10 or 20 years is there's no quarterback. So in the good old days, and I keep talking about that, if you were to call your family doctor or internist and you had stomach pains, you would go to the hospital, and if the emergency room doctor thought you needed to be in the hospital, your family doctor would admit you to the hospital and at the end of the day come and see you every day. And when you went home, he would be the one that discharged you, and he would see you when you came back. I say right now that everyone is in charge and no one is in charge. So if you go to the emergency room where you don't have any choice in who that doctor is, and that's kind of always been that way, and you have to be admitted to the hospital, say with pneumonia, and you're admitted to the hospital, 9 times out of 10 when you're admitted, a hospitalist takes care of you. Now that's an interesting name. It comes from the fact that they only work in the hospital that makes you think that they work for the hospital. That is someone you don't get to choose. And when they admit you, they no longer call your family doctor and say you've been admitted. Why? They don't have to. There's no customer service involved. They work for the hospital. And their answer to that is the records are electronic. The doctor can just retrieve them whenever they want. Try to do that. When you're in the hospital under the care of a hospitalist, depending on their work shifts, that will change during your hospitalization. So now you have a second doctor you've never met before and had no choice in choosing. And they then send you home. And when you call up your family doctor and say, I'm supposed to see you because I had pneumonia, they'll go, we didn't know. There is no one in charge of your care. Continuity of care has fallen by its wayside. When I used to get called to the emergency room because, let's say, Mal Jr. here had chest pains, and I wanted to put him in the hospital, I would call his family doctor from the emergency room and say, I'm putting Mal in the hospital, could be a heart problem, I'm not sure. And when I was done evaluating him 1, 2, 3, 4 days later, I would call that family doctor and say what we found, and he's being sent home, and by the next day a tight note would be on that family doctor's desk. I did that for 2 reasons. Number one, it's good business, and number two, it's good patient care. None of that happens anymore. Okay, I got to give you 3 examples. Am I doing okay on time, Barry? Keep going, okay. The Ohio checkup. Okay, these have all happened recently, except say maybe in the one that. We have a good friend in Columbus, Ohio, well-educated guy, he's in the transportation industry for years, he's retired. So he calls me up and says, David, I just went to see my new internist. I said, man, you're lucky you were able to go to a good doctor. He says, well, I went in, and for about 25 minutes, he sat looking at his tablet, asking me lots of questions. I said, okay, that's going to happen. I said, what happened next? He says, nothing. The doctor looked up and said, well, that's it. We're going to order these tests, and I'll see you in a year. The doctor never physically touched my friend Jim. Never examined his heart, his lungs, looked for a thyroid problem, look in his ears, his eyes, feel his pulses. No physical examination. That's malpractice. You cannot take care of people unless you understand them and you examine their body. He never even took off his shirt. Then tetanus obsession. I talked about this last time. This one really aggravates me. So this is about 2 years ago, and this is my mother-in-law, Marge, who's since passed away. And she was a complicated patient. Let me tell you, she's the most complicated patient I ever took care of, but I didn't take care of her. I monitored her care. She had bad peripheral vascular disease. She had lost a kidney to that. She had blockages in her neck, blockages in her legs. She had pain when she would walk. She had infarcted most of her bowel in 2006 and only had about 6 feet of bowel. She only had 1 kidney. So very complicated, and was going to what I thought was a very good internist in town who has a tablet. Okay? So when you go into the doctor's office and you see the tablet, remember, okay? So he's going through the checklist. In the meantime, Marge had blood work done about a week before that had shown her one last kidney was deteriorating. You could tell that from the blood test. So he's going through his checklist, and I'm waiting for him to get to the kidney. And he asked Marge, when was the last time you had a tetanus shot? Marge was 80 years old at the time, and she says, probably when I was 10. So she managed to live 70 years without getting tetanus, but he wanted to know about when she had a tetanus shot. He then spends about 5 minutes telling us why it's important to get a tetanus shot. And I finally say, okay, give her the tetanus shot. We can't do that. You got to go to the public health service to get your tetanus shot. So this is an 80-year-old lady who said, okay, give it to me. Let's quit talking about it. But now she has to go somewhere else to get the tetanus shot. But it doesn't stop there. Because now tetanus isn't all by itself. You get diphtheria and pertussis at the same time. Neither of which adults get. So finally we say, okay, and I'm waiting for him to get to the kidney. He goes through a bunch of other things. He wants to know if Marge has any firearms in the house. I thought she was going to say, if I did, I would shoot you. That's the way Marge was. So we finally finished, and he says, okay, that's it for the day. And I said, what about her kidney test? She had a kidney test done? I said, yeah, it's supposed to be in the electronic medical record. So 33 clicks later, he says, oh yes, it's deteriorated. But we're out of time, you have to make another appointment. That is a true story. Marge ended up dying of lung cancer, and not once during her care did he ever take a history that she was a chronic smoker and needed a chest x-ray. The last one is a good one for a friend of ours. This happened recently. Elderly gentleman, real good guy, had bronchitis, went to see his family doctor who actually saw him. Said, you got bronchitis, put him on an antibiotic. About 4 or 5 days later, patient's not any better. It's Friday afternoon at 3 o'clock. He calls the doctor's office and says, I'm not getting any better. Now, in the good old days, the doctor would say, come over to the office, because we already know you. We know what medicine you're on. We'll examine you. We might change your antibiotic. Instead, this patient is instructed, go to the ER. Friday afternoon, he's in his 80s. He's going to go to the ER, and they're not going to know anything about it. And we're going to waste all that time and money and tests that something could have occurred in a doctor's office in about 5 minutes. Where is this headed? If you want to have a better attitude the rest of the day, you're welcome to leave at this point, because it's going to get nasty now. Costs are going to be uncontrollable. So just talking with Christensen, he has to expend $9,000 a year before he gets any benefit from his insurance. That is going to worsen. Before I went on Medicare, my premiums plus deductible were $17,000 a year before I would ever get a single dollar of benefit. Costs are going to become uncontrollable for 2 reasons. Over-testing because of electronic medical records and the aging of the population. Access is going to be intolerable. I got to wait 8 months to get a colonoscopy. In the good old days, gastroenterology groups competed with each other. You wouldn't wait more than a week for an elective colonoscopy. Because if I wouldn't do it, someone else would. There is no competition among physicians anymore. You're going to get less and less care by physicians, which may or may not be bad or good, depending on the physician. And nurse practitioners and PAs will substitute. They are already indoctrinating our kids to expect the nurse to render your care because they are school nurses. When I went to school, there were no school nurses. If you got hurt, you just either went home or went to the teacher. So they're getting used to being cared for by non-physicians. Now, where is this going to go? There's a nice saying that says, eventually everybody has to sit down to a banquet of consequences. So the things that have been in motion for 20 years, we're about to have at the table. The first thing is we're going to go to a single payer system, and not a single person will complain. Yeah, I see that dumb look, okay? No one will complain. Why? Because the cost for health insurance will be so outrageous, they will gladly take a government program that's either subsidized or free. So if I were to ask Christensen if he could have a policy for $800 a year instead of $9,000 if it was single payer, that's a no-brainer. The next thing is there's going to be hospital consolidation, because the first thing that's going to happen after the government controls paying for health care, they will realize we can't pay for it. We can print the money, but that's bad. So what we're going to do is cut reimbursement. And because we're the only game in town, you got to take what we're going to give you. And it's not going to be a 50% haircut right off the bat, but it's going to be decreasing amounts of revenue. The only way to survive will be hospital consolidation. So I'll give you another example. We have a fine hospital here at YMC. We actually do open heart surgery here. They just reported their 2015 numbers. We did 153 open heart cases last year. I just sent a friend to the Cleveland Clinic who had an unusual kind of heart problem, and he was operated on there, and the day he was operated on, they did 28 open heart procedures in one day. They do more open heart procedures in 1 week than we do in a year. It's only going to be hospitals like that who can do the volume to take a decreased payment. So sometime in the next future, our hospital will probably be associated with somebody. Banner, Shea, Mayo Clinic, I don't know who, but a standalone hospital is not going to be able to take it once we go to single payer. And no one is going to complain about single payer because it's going to be so bad already by the time they do it. The next thing is doctors will unionize, because the first thing the hospital will do when they get less money is pay the doctors less. And physicians will become what I like to say like airline pilots. A respected professional position, lots of training required. They handle people's lives on a daily basis. They make a pretty good living, not a great living. And doctors will be more and more like pilots, and they will unionize to control their future. All of this is going to happen sometime in the next 8 to 15 years. Depends on the economy more than anything else. What can you do? Okay, it's kind of like a prepper, doom preppers, My best piece of advice, do not get sick. Okay? Yeah, exactly. Stay out of the hospital. So do all the things you're supposed to do, because getting sick is the worst thing that can happen to you. If you can't do that, you have three choices. You can be extremely wealthy so that you can go to those few places that still take cash, like the Cleveland Clinic or the Mayo Clinic or some of those famous clinics. And I don't mean wealthy like you've done okay. I mean hundreds of millions of dollars, where you fly in your own jet or you take the doctor and fly them to you. The next best thing, and it's too late for most of us, make sure you got a doctor in the family, particularly where you live, because it doesn't do as much good if they're in California and you're in Georgia. Okay, so that helps a lot. And then my last piece of advice is speak up. If something happens to you at a doctor's office, in the emergency room, in the hospital that you do not understand, that doesn't make sense, say stop. Explain what are you doing and why are you doing it. You're stopping my medicine I've been on for 15 years. Explain why that has to happen. Because we've been trained in the last 15 years to walk on eggshells with our healthcare professionals, because we're afraid they will fire us. When I was in practice, I was afraid you would fire me. And that's how it's turned around in these years.
There's a fourth one.
Yes.
Join the military.
Well, I didn't want to talk. Yeah. I'll be glad to come back and talk about government health care under the military system another time. That's a potential possibility. So those who are World War II and Korean veterans I talked to last time, it's still FUBAR, okay? It's still fouled up beyond all recognition. And every time I go to the hospital, Pam will tell you, I almost have to take a blood pressure medicine. I get so mad at what I see happening to care. So with that, I'll stop, and if we've got time, I'll answer a few questions. Do we have? We're done. We're done. I'll see you afterwards. Thank you.